everybody, welcome back to the Overrun Podcast. Ed Bauter here. Dan is off today, and I'm here with Greg Clopp. Greg is a former paramedic, and he's now a nurse anesthetist that works out in Washington State. Greg, thanks for joining me today, man.
Man, thanks for having me. Pleasure to be here.
Yeah, I'm happy to talk to you. Greg and I, we worked together years ago. I like the old Monarch 1 shirt that you got going on there.
Figured I'd try and bring sexy back.
I know, we're bringing back old projects here. So it's a good time. A couple of New Jersey medics talking about RSI. So, Greg, I wanted to bring you on today because I think your experience is kind of unique, where you worked as a medic for a long time, did what a lot of us have decided to do after that and move on into nursing. You moved on into anesthesiology. So I couldn't think of someone who had a better reference point to talk about RSI here than someone who's kind of seen it on both sides. So last month, we had Dr. Eddie Gutierrez on talking about different pressors in RSI and in sepsis and shock states. And I want to talk to you today about RSI because there's a lot of data, a lot of information that's always coming out about RSI, what we're doing right, what we're doing wrong. I think we generally have the algorithms down, but now we're finding out more things about what works, what doesn't work in RSI. So that's what I want to talk to you about today. So let's start with a kind of a 10,000 foot view from where we started, 15 years ago using etomidate and all that kind of stuff to where we are now. I guess the first question is, we know that RSI, I think, is still good. Is it a procedure that's getting better, that's more useful in the field? Or do you think that we're getting into kind of nuances with RSI that aren't necessarily helpful in the field?
Well, it's hard for me to say whether it's getting better in the field or not, because I've been out of the field for about 7 years now. I kept spending time in EMS even after I got my RN. I kept spending time in EMS even after I became an RN, even after I worked in the neuro ICU, even after I went to anesthesia school. I think RSI is taken much more seriously overall these days. When we first brought it to the field, it seemed like everyone was like, oh, this is the way to go. This is the way to intubate everybody. You just dump a bunch of stuff in them and you paralyze them.
Well, it felt like that new toy, right? Like it's like
here's
a
right?
new thing.
And and it was easy to love because it was great. I remember the first time I did it. I was in Irvington, New Jersey. I think I was probably with Mike Fajardo. And if it wasn't Mike, it was one of his doppelgangers up there. But we were in Irvington, New Jersey. We had a patient with congestive heart failure. I started in the field when you used to have to wrestle these people down and, you could CPAP them for a little bit and then intubate them. Like, I was working with guys that had we held them and shoved it in their nose stories.
Mm-hmm. Yeah, 2 milligrams of Versed in a nasal intubation, right?
Right. So, we've got this guy, he's in extremis, he needs to be intubated, he's all over the place, he can't even hold still. I call the doc and he's like, do the RSI, do this, do that, do this. And I'm like, great, here we go. And I got to tell you, once the guy was out and paralyzed, it was the smoothest, most beautiful intubation we'd ever done in the field. And we finished up and we looked at each other and we were like,
like, oh, we found it.
Wow. Was it good for you? And then it seemed like everybody was RSI, like everything, It's like, oh, we had this guy with a fractured ankle, we RSI'd him. And I was like, okay. And then it was like we had a 6-year-old and we RSI'd him.
Right. And you're like, ooh, that's a bit young,
well,
but all right.
Okay. Maybe they needed it, maybe not, And then it started to come around like we RSI'd this guy and we killed him.
Right.
Oops.
Yeah.
And just like everything else in that, well, I go back to the days of tackle box. It's just like everything else in that tackle box. It's a tool and you have to have a lot of respect for it and a lot of love for it. It's great, but you have to apply it the right way. One size doesn't fit all. One of the things we forget is how far a little bit of something goes a long way. A patient who's critically ill and hypoxic and full of CO2 is halfway sedated already. We don't bring patients like that to the OR unless we have to. Mm-hmm. And when we do, it doesn't take much. Even an anxious 30-year-old with nothing on board will surprise you. I've given 2 milligrams of Versed to a 70-kilogram 30-year-old woman who's all upset and agitated and nervous about her surgery, and she goes apneic.
Right. Well, and that might lead to more to the question where, did we get to a scenario where if your only tool is a hammer, everything looks like a nail? Right.
Yeah, I think we were probably there for a little while.
And it's good, I think, to see at least, you know, it feels like as an industry, we're kind of, we sort of like overcorrected, right? Where, you know, we're using CPAP, we're doing all these things. Now we have RSI. And if you imagine like a bell curve, right? We're like, all right, now we're going to RSI everybody. All right. Then we realized we were killing people and we're not doing what we're trying to do. So now let's try and correct it. And I agree. I think that sometimes maybe like, and we've talked about, you know, using a DSI instead of RSI where, you know, it might be that maybe the patient, their anxiety just needs some sort of anxiolytic and maybe that solves everything. But one of the things I think that could probably solve everything is if medics had propofol, which we, in a lot of projects, they don't. So I'm wondering how you're feeling about that and adding that to the armamentarium as, so using something like propofol and having that as an option, as opposed to, you know, the option is RSI or nothing. You know, do you feel like that might be something that can be beneficial to kind of add to that armamentarium, or, you know, are there too many variables with a drug like that it doesn't necessarily benefit us?
As though it doesn't necessarily benefit field use. Propofol is a fantastic anesthetic drug. It's extremely useful. You can dial it in. Everybody, you know, everybody's got a range of effect. You know,
Mm-hmm.
I look at someone and I'm like, oh yeah, I give this guy like 100, he'll be out. And I go to a place in LMA and we're not paralyzing. And I go to a place in LMA and the guy reaches up and tries to help me. The next case, we're doing another LMA. I got this gigantic guy on the table. He's young, he's strong, he's all worked up, he's agitated. I'm like, oh, this guy's going to need a lot more propofol. So I give him a couple different things, and I give him 200 of propofol, and his blood pressure goes to 40.
Mm-hmm.
So, well, that was plenty. So, you know, it's another useful tool, but it has its drawbacks. I don't like using etomidate in septic patients because it
Mm-hmm.
really does screw with the outcome. Etomidate is a useful drug if you're trying not to tip over and blow out the last little bit of cardiac function that you have. Because propofol is a direct cardiac depressant. So when I have someone come in who's in trouble and not doing well and running out of catecholamines and their heart's not very happy, I reach for etomidate still. And I think that's still the only thing you have in the field.
Yeah, it's typically we have etomidate or ketamine, and those are really the two biggest ones. And certainly,
Which is interesting because those are two completely different medications.
Right.
Yeah. You know, I'd like to see more choice. You do have fentanyl on the truck, so you could do like a heavy fentanyl induction. Fentanyl is great if you're doing it that way. It's why they use it in the cardiac OR because it doesn't depress cardiac function.
Right.
So you can take someone with an ejection fraction of 10 who needs a new heart, and you give them a little bit of Versed and a whopping dose of fentanyl and very little propofol or etomidate.
Mm-hmm.
But I think what's interesting in the OR, we like to give a balanced anesthetic, and granted, a lot of it's planned, and we have time.
Yeah.
And I can give you a little bit of Versed while we're hooking up the monitors, and I can give you some Zofran, and I can have you breathe oxygen the whole time for 5 minutes.
Have a nice conversation about it beforehand.
Right, and we tell some dumb jokes, and
Right.
you know, we laugh about how cold the EKG stickers are, and you know, and it's the same dumb jokes all day. But then when we get ready to fall asleep, we're fully oxygenated. I have all the time in the world, even on a patient who's a full stomach. Most of the time, I have time to do lots of things and have lots of things on the patient and in the patient. And then I give you some Zofran, and then I give you a little fentanyl, and then I give you a little lidocaine, and then I give you a little propofol, and then I give you a little paralytic. In the field, if your choice is etomidate or ketamine, then you're stuck with a whopping dose of either one, and you're going to see all of the effects of whatever thing that you picked. I see less drop in my blood pressure for propofol because I can give less propofol because I give a big dose of lidocaine and I give a little bit of fentanyl.
Right.
So
I think the pushback typically with fentanyl is that it doesn't have it has the analgesic properties, but not the sedative properties that you're looking for. Which
in higher doses, it's got plenty of sedating properties. Is the trick. Yeah.
But I think that's the variable is, so maybe it's the issue is that we have these drugs, but we're not allowed to use them in the most effective way. And that might be a protocol problem. That might be, you know, catering to the lowest common denominator, right? Because, you know, some provider out there might bolus a gram of fentanyl, and you know, now nobody can use it because you take one person, it takes away all of our fun, right?
Right, but that's the trick about a fentanyl induction, right? You're probably still carrying 100 microgram vials, 2 mLs. You might have the 5 ml, 250 microgram vials. If you're walking into a cardiac OR and you're going to do basically a fentanyl induction with that as your primary agent, you're grabbing a bottle that is 1 gram of fentanyl. And the first time you see that bottle, it really blows your mind. I have a photo. I'd have to dig through my cloud drive, but I have a photo of a 1 gram fentanyl vial. It's humongous.
Right.
It's 4 250 mic vials put together. It's 20 mLs of fentanyl. And you're like,
It feels like a lot of fentanyl. But I guess that's part of the interesting question is there's an obvious disconnect between what's done in the hospital and what's done in the field. And I think a lot of times that's sort of attributed to, well, they're only in the field for 20 minutes, or medics don't have the same training as anesthesiologists and like that. And I'm wondering what your feeling on conservative dosage in the field is.
well, I don't think it's fair to limit something. I don't think it's fair to limit a treatment or a way of doing things because you don't have a lot of time with the patient.
Yeah, I think that's right. Well, obviously everything in EMS is 20 to 30 minutes and you're out, right?
Yeah, which is great, which is why I love EMS, because if I don't like you, I'm done with you in 20 minutes. But I think it's not fair to be like, well, we don't need to carry this, or we don't need to do this, or we don't need to have this option because we're only with the patient in 20 minutes. They can just get it at the hospital. And I think that's not really fair to do.
Yeah, it occurs to me like the whole reason that we're there is to do things in the field.
Yeah, and I think we need to be on top of things, and I think we need to be aggressive about doing these things. There's some logistics at play. Like, you can't carry 4 grams of fentanyl on an ambulance on the street.
Sure.
You won't have any by the end of the day. There will be police reports. There might be violence involved. The last thing you want is Joe on the corner realizing that you've got his month's worth of fentanyl stock.
Yeah, right. That's why we double lock our narcs.
Exactly. You're going to need a bigger lock. But regardless of the time you have with patients, I think it's important to have these different options. I can think of a few patients I had in the OR where if I just did like a ketamine induction, things are going to get haywire.
So what's your response to, I guess, we need to paralyze patients to intubate them? Because I think when RSI came out, and I mean, we're pushing back 20 years now, but when RSI came out, like we said, it was kind of this cudgel that you used for everything. And now in the literature and in practice, DSI is becoming a lot more prevalent. So I guess, do we feel like that's an overcorrection, or was it, we never needed to RSI everybody, but we're only just kind of figuring that out now?
DSI, or delayed sequence induction or intubation, I think it's a really good tool. I mean, it's pretty much what I do almost every day. I very rarely RSI anybody. And when we're talking about someone who's critically ill, if you give things one step at a time, you can see what each thing is doing.
Mm-hmm.
So if I give you a little bit of Versed and you go apneic, I can intervene with that and I can breathe for you and I can make sure that your blood pressure is okay. If I give you a little bit of fentanyl and your blood pressure tanks a little bit, I can treat your blood pressure with like a push dose pressor. RSI, rapid sequence induction, is great, but it just means you push all the drugs at the same time, and that's not always appropriate. DSI doesn't necessarily mean we're not going to use paralytics. It just means we're not going to give them at the same time we give all your sedatives.
So the functional difference is waiting to see what the medication does before you go on to the next intervention.
Essentially, yeah, making sure that you didn't burn a bridge that you can't get back.
Yeah. No, and I think that's right. And again, in your traumatic arrests and your patient has trismus or whatever else, there's certainly a place for RSI, right? Like,
absolutely.
This,
your full stomach that you don't have the time to let them be unconscious and regurgitate. Yeah, absolutely. Right.
So I guess I wonder if that's kind of how RSI became the preferred thing, because we don't have patients that are NPO. And, so maybe the assumption was everyone's going to have a full stomach, so let's go ahead and paralyze them to get rid of that concern. But I just like everything else, I think that there's kind of this almost like a middle ground where you can find, right, where, it doesn't have to be wholesale, we only do this or we only do this, where, all right, maybe this patient, their biggest problem was, anxiety that's compounded by whatever pathology they have. So maybe, some kind of benzo, knock them down a little bit. I'm going to operate under the thought that we don't have propofol because there's a lot of systems that don't carry propofol for whatever reason. But it might be, all right, give them Versed, give them Ativan, whatever. Let's see what that actually does. All right, let's give them 50 mics of fentanyl. Let's see what that actually does. Let's give them, 50 of ketamine. Let's see what that does. And if you still need to intubate them, okay, now we move on to that conversation while preparing for that the entire time, right? I would rather prepare to intubate somebody and then not have to do it.
I think
right?
That's the best case scenario of all,
Right, exactly.
Someone who's having significant pulmonary edema, who's got real bad trouble breathing, you give them a little bit of medication to help them calm down and not feel that air hunger. And you start putting your stuff together and you turn around and the O2 sat's 98% and they're taking nice deep breaths and they're working with the CPAP instead of against it. Okay, let's go to lunch.
Yeah. And that might, and operationally for medics, it might be, you call in and you get orders for everything, but that doesn't mean that you have to do everything. Right. So
that's an important distinction. You should be able to stop when you get to a point where it's an effective treatment for the patient. If you're trying to get someone's pulse ox up and you reach that point and they're not falling asleep and continuing to circle the drain, stop there.
And I think that might be kind of an important way to approach it, where I worry sometimes that, you're given orders from a physician and you're like, well, these orders must be completed, to the letter. And it's kind of like, but that's not really, it's not necessarily the spirit of what we're trying to do here. Something that I do want to mention, because we talked about skills here, we've got this 2021 paper talking about cervical spine injury secondary to using a video laryngoscope. And I want to get your thoughts on this. This is actually something that you brought up when we started here. So we've got this paper up. This is coming out of anesthesiology. And essentially what's important here is the picture in this file it shows hyperangulation of the neck through the actual procedure. So we talked about this off air. When we talk about doing video laryngoscopy, this is another thing where now it's super popular and maybe this is something that we can use for everybody, but obviously there's variables to this as well.
Yeah, video laryngoscopy is an incredibly important tool. I have a particular brand of video scope in every single anesthesia cart where I work. Terrific. But a lot of people have the misconception that video laryngoscopy eliminates movement in the neck. So just the other day, I had a student with me, and we had a patient who had some cervical spine issues and would get, if they lifted all the way up, get tingling in their fingers. If they twisted their head all the way, they'd get pain in their shoulder. And I was like, all right, I look at my student. I go, okay, what are we going to do to prevent from aggravating this cervical spine issue and damaging nerves when we go to sleep for this gallbladder? And she goes, well, we're going to use the video. I said, is that going to prevent movement of her C-spine? And she goes, well, yeah. And I go, well, no. Look at this. And you can find lots of literature about people who have traumatic injuries and unstable C-spine injuries who get made worse by intubation. And you can find a bunch of stories, and this is perhaps the most dramatic, about someone with significant spine issues. This was an 84-year-old woman. She had a condition that basically, and there's a rheumatologist out there who's going to start twitching in a moment, but this woman has a condition where basically she has severe arthritis in her neck. She has autofusion of her vertebra. So that wacky looking x-ray on the left side that's the way her neck just stays. She just can't. Is. Yeah, that's the way she is. She can't move her neck. She has no range of motion. And unfortunately, she's so brittle from her osteoporosis that when they put in a glide scope and lifted and pulled on all those pushed on all those soft tissues, which pulled on all that arthritic brittle spine, it snapped.
Yeah. And what you can see in the picture here is it looks right around the area of C4, C5. There is a 125 degree angle.
It's really aesthetic.
Yeah.
And considering where she started and where she ended up, it's profoundly astounding there. And it's important.
For the listeners, this patient had ankylosing spondylitis, which is something that's a medical school illness that you hear about a lot. You don't hear about it a lot necessarily in the field, but essentially just very, very brittle arthritis. And this is a procedure where, if you're watching on the video, you can see this hyperangulation of the neck. If you're listening on audio, essentially this patient's the occiput of this patient's head hyperextended their neck about 125 degrees. And there's a very dramatic we'll call it a distraction injury.
Oh, it's distracting.
That's it's distracting. All right. So, but again, this kind of speaks to, when people talk about, oh, it's a low risk skill, there's really not a lot of problems that can be encountered with it. Again, the overwhelming amount of patients that we're going to be intubating tend to be older. And this is something that I think needs to be considered, right? Where, all right, if we save their airway, but we fracture their neck, what actual progress have we really made?
Yeah, I mean, if I go from being unresponsive and not maintaining my own airway to being a quadriplegic, I don't know as though I'm going to I don't know as I'm going to thank you afterwards.
All right. I'm still alive, but at what cost?
And the important point is, an injury like this is not going to happen to you or me, even in an emergency scenario. We can manipulate my neck soft tissues, and I've got plenty of it these days, but we can manipulate my neck soft tissue as much as we want, and my C-spine is going to hold up to it. But somebody who has an unstable C-spine or has a traumatic injury, or is incredibly brittle from one of these conditions that are out there, just using the VL does not actually prevent the C-spine itself from moving. And it's important that even when we're in a huge hurry, especially when we're RSIing in a hurry from the get-go, we still have to be very careful and very deliberate and very purposeful in our movements and make sure we're not just like bullying our way through something.
Yeah, no, I think that's right. And there's been a lot of talk about, safety timeouts and like that before you actually go into a procedure. And I think a lot of times those are focused on, do we have the right meds? Do we have, all the right tools? But I think sometimes those talks also have to get into, are we doing the right procedure? Are we prepared to do, like, are we, catecholamine depleted enough, right? That I'm not my excitation isn't causing more problems with what's about to happen to this patient.
And not only are we doing the right procedure, but are we doing it in the right way?
Yep. No, I think that's a big thing too. Just real quick before we get into the next thing, again, we talked last week about temporizing pressures. Do you have a preferred push dose pressor in these kind of settings? It's essentially norepinephrine became the big thing, right? Last month in our chat was just we can pretty much give norepi to everybody safely.
Agree with that statement. I very rarely use push dose norepi because most of the time I have a healthy patient who's hydrated and not in distress and hasn't thrown away all their catecholamines on some useless thing like trying to stay alive. So I usually reach for phenylephrine and ephedrine. If I'm looking at someone who's kind of fragile and I'm expecting their pressure to drop from the few different things that I'm giving them, I'm probably going to reach for ephedrine first because, like norepinephrine, it has peripheral effects and it has central effects, and it kind of helps balance out, right? So I'm giving a little propofol that's depressing the heart. The ephedrine's going to balance that out. I'm giving a little bit of fentanyl and I'm taking away all the stimulation and the blood vessels are relaxing, and ephedrine's going to help that out. So I primarily, reach for ephedrine, which is like norepinephrine light.
Right.
And I primarily reach for phenylephrine, again, because they're a little bit further down the scale of heavy hitters, so to speak. But I think norepinephrine is a fantastic push dose pressor. And I think if you have a patient who's soft on their pressure or looks extremely fragile, I think putting it in the mix and giving it with what's going to tip things over at the same time, I think it's a great idea.
Mm-hmm. Yeah, and I think that the conversations are kind of pushing a little bit more toward, your RSI bundle is now expanded into choices of drugs instead of, you have to give this, right? Where, I think there was a time, and, you worked on aircrafts before where you've got, your pocket pouch of 4 medicines, right? And I think that's sort of evolving to like, all right, now you might have 12 medicines available to you, but which 12 you use is going to depend on the patient or the time or the provider. And I think there's a lot of variability that's kind of being added to that. And so we've talked a lot about RSI and all this stuff, and we've certainly talked about it a lot over the past couple months. Something that I wanted to ask you and spend a little bit of time on before we get out of here, because we're starting to get into the time where people are looking to apply into programs and figure out what they're doing with their life. Greg, I had the privilege of knowing you when you were a medic and to watch you go through nursing and, anesthesia and all that kind of stuff. So, and certainly both of our career paths have been non-traditional. I want to
but we've had fun.
I know, boy, hasn't it been a blast. um, but I want to get some of your opinions, I guess, for students or for providers who are looking, your typical EMT or entry level medic who's looking to grow in the industry but doesn't really know where to go. Because I think that in the industry we have a lot of conversations of like, just go to nursing school, right? Just go to nursing school, just go on and do that. And what that ends up doing is it ends up reducing the amount of EMS workers that we actually have in the field. So
Which is a real shame because there's not enough to go around to begin with.
No, exactly. And that's kind of what I want to talk about, where I guess I want to get your opinions on what can we do to help the industry grow, and then talk to, I guess, some of the providers who are considering, nursing or anesthesia or, med school or whatever else.
Well, I think you have to sit down and you have to ask yourself, like, what do I want to be when I grow up? Do I love being on an ambulance, but I want to be able to make a living at it? And if you love being out in the field doing EMS and you want to make a living at it, move away from the East Coast. Right?
Yeah,
Everything.
I mean, it's the unfortunate reality, but yeah.
Everything, part of the reason I don't have a side job in EMS anymore on the West Coast in Washington is because everything out here is fire-based.
Mhm.
There's a few places in really rural areas, and I don't feel like driving over an hour or so to go volunteer, that have volunteer EMS, including volunteer ALS. But for the most part, in any populated area, it's fire-based. So they're not relying on Medicare and Medicaid reimbursement to pay the bills. They're relying on tax money. And because it's the type of service that everybody understands, it's well supported by the tax dollars, and you can actually make a living out here being a full-time paramedic. If I knew that 30 years ago, I probably would have relocated to the West Coast and gone to like the King County Medic program, but I'd probably still be a full-time paramedic today.
Who would have thought Seattle has a great program? Crazy.
Right, I know. But who would have thought that, like, out here, even in Snohomish County, an hour north of Seattle, who would have thought that our people get paid well enough that they can make a living and afford a house and have a pension?
Mm-hmm.
Now
it's a whole other thing that's a novel concept too. That's a whole other conversation.
Right. Like this might be an earth-shattering idea to somebody, but if you're looking at that ambulance and you're like, I want that to be my office until I retire, pack your shit and move 2,600 miles away. It's that simple. It's also gorgeous out here, so you'll be okay. There's no such thing as just a paramedic. But if you want to pursue some advanced education, if you want to get into, college level anatomy and physiology for the fourth time, if you want to get into graduate level science courses, if you're more on the touchy-feely side and you want to get into graduate level, research courses and things like that, I would say, all right, then it doesn't matter where you are. You want to take the next step and you want to start working on a nursing degree and pursuing a bachelor's degree, or work on an education degree and look towards research and stuff like that. I'm a science nerd and I love the way the human body works on a molecular level. And I love like learning about what these medications do. And I love the technology that lets me do it. An IV pump if an IV pump makes you want to pull your hair out, do not go to nursing school. But if you're like,
if those songs aren't lullabies to you,
right? But if that thing starts singing and you go, I know how to put you to sleep, buddy. Like I can make this technology do what it's supposed to do. Then go to nursing school and go to an advanced practice nursing program and look to be, one of the hands-on type of nurse practitioners, or a CRNA, or find a place that has paramedics getting advanced degrees and doing all kinds of interesting things and working on places. If you want to change tactics, if you don't want to go to medical school, go be a physician's assistant. We have physician's assistants that are functioning almost as if they were a first assist, and they're doing 80-90% of the surgery, if that's what you're interested in.
Yeah, I think that I think it's a shame that we've kind of gotten to a point where we have to encourage people to look outside of the industry to improve the industry. You know what I mean? But we have kind of put ourselves in a position where it's a nationwide problem where there's a million providers and there's 1,000 supervisors, managers, or whatever, and it causes a really significant bottleneck as far as upward mobility is concerned. So I think that a lot of this, like there's plenty of clinical medicine that you can practice as a paramedic, right? But it's how long can you be a staff medic and still, make a living wage and still be able to make the difference that you want to make. And certainly something we've talked about on the show plenty of times. It's a tragedy that we have to push people away from the industry so that they can afford to eat.
Yeah,
but
I mean that's the real sad part about it. Like, bottom line is, like, look at what you're doing and look at the things that you like, and that'll guide you into where you want to go. But unfortunately, if you want to be able to have lunch, you might have to, hang up.
Sometimes I like to put ketchup on my sandwiches, so I have to get a second job for it.
Right, like you might have to put your EMS boots on the shelf and put on a pair of white nursing shoes in order to feed your kids.
Yeah. And again, that's something that we've discussed at length, and it's a shame. Greg, thanks so much for your input, man. I wanted to get the idea, the talk from someone who started in EMS and who moved on to other things, but still kind of has the thought process and the passion behind it. So, thanks for all the insight for, which drugs will work, and then also that little bit for career progress. Thank you guys so much for listening. For the Overrun, I'm Ed Bauter. Danny is off today. Greg, thanks again. Check out all of our stuff on EMS1 on YouTube and wherever we are on the internet. Download our podcast. And for the Overrun podcast, Ed Bauter, we'll talk to you all next time.